It's okay if we start.
I'm good.
I want to thank everybody for joining us today for National Public Health Week. This will round out our series of speakers brought to you by the Arkansas Colleges of Health Education MPH program. My name is Don Simpson. I'm privileged to serve as program director and faculty with the MPH program. And today we have Dr. Morreale, Dr. Carol Morreale will be presenting. Before we start, excuse me, I'd like to read a land acknowledgement and also encourage you, if you have any questions, to submit those in the chat, and we'll let Dr. Morreale respond to those at the conclusion of her presentation. We are on the unceded homelands of Native peoples who have ongoing cultural and spiritual connections to the places we live. We acknowledge and send gratitude to the land and to the people who have stewarded it through the generations. In acknowledging this history, we do not intend a superficial action that somehow releases us from the obligations of righting past wrongs. We acknowledge that we live in a world where privileged peoples have gained wealth by colonizing, enslaving, and oppressing other peoples and communities. We see the ongoing effects of these practices and policies every day, and we work to be accountable to our part in this history. We each come from a different history. We each have lived a unique life. We bring those experiences to the work we do today. We affirm and celebrate our commitment to the difficult and joyous work we must do to transform our communities into ones built on justice and on caring for each other and our lands. Dr. Carol Morreale is a pharmacist and professor of pharmacology at AIC at the Arkansas Colleges of Health Education. Prior to joining AIC, she was the director of interprofessional education and public health at William Carey University College of Osteopathic Medicine in Hattiesburg, Mississippi. Dr. Morreale holds a Doctor of Pharmacy degree from Temple University School of Pharmacy and completed residency training at the Medical College of Virginia, specializing in adult critical care. She has a bachelor's degree in nutrition sciences from Rutgers University and received her master's in public health from the University of Southern Mississippi and her Master of Science in Population Health Management from the John D. Bower School of Population Health at the University of Mississippi Medical Center. She's board certified in geriatrics and currently serves on the Pharmacy Educators and Research Council of the American Society of Consultant Pharmacists. In addition to researching students' attitudes toward integrating interprofessional education and experiential learning into the osteopathic curriculum, her research interest in geriatrics includes the impact of medical education in elder abuse on physician recognition and response to abuse and neglect. We're very excited today to have Dr. Morreale speak to us about end-of-life care being a public health concern. Thank you, Dr. Morreale.
Thank you for the introduction. So just to get the business part out of the way, as far as disclosures, I do not have any financial relationships with ineligible companies to disclose, nor do the planning members and others in control of this content. And as far as commercial support, AIC and ARCOM acknowledge that there is no commercial support was received for this activity. So for my learning objectives today, we're going to describe the demographic, medical, and societal trends that make end-of-life care a growing public health concern, identifying some of the barriers and challenges in delivering equitable person-centered care across diverse populations. Want to explain the role of public health in addressing grief, bereavement, and the systemic integration of palliative and hospice care. Evaluate the impact of policy, legislation, and technology on the accessibility and quality of end-of-life care and grief support services, and discuss best practices and community-based strategies to support advanced care planning and health literacy, along with culturally competent end-of-life interventions. So hopefully we'll get to cover all of that today. So the U.S. population is growing older. And with senescence, there is really this inevitable end of life and grief that occurs. And end of life is a public health issue. Many people don't think of it as a public health issue. And the reason why I say it is a public health issue is that grief advocacy and management are prevention. And that's what we're about in public health. We focus on prevention. Um, and although public health and allied health fields may perceive that end of life issues and grief are beyond their scope of practice right now, core public health values and principles have much to offer people who are dying, along with their families and their communities. And I stress communities because, especially in states like Arkansas, Mississippi, where I came from before coming to Arkansas, many rural communities, when somebody passes, that the community grieves. And we have to recognize that fact and learn how to help those communities deal with the grief that befalls them. So in 1948, the World Health Organization defined health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So especially when we consider end-of-life issues, making the absence of infirmity is impossible. You just can't. Public health still has much to offer, though, in terms of facilitating well-being for individuals. Um, Many end-of-life experiences result in multiple grievers, like I mentioned before, besides the individual or their immediate family, both in the face of clear loss, such as death itself, and ambiguous loss, such as cognitive decline. So we also have to think about, it's not only death, but that cognitive decline that we're starting to see in a lot of our older adults. And then again, as the primary cause of death has shifted from infectious disease to chronic disease, it's been estimated that for every death in a community, approximately 4 to 30 people are left to cope and mourn with the loss. So we're not only talking again about that end of life care for the person, but for the community as well, the community that is feeling that grief and loss. So traditionally, public health responses to death have been one of specialization. Really, we've got embalmers, we've got coroners, we've got funeral directors. However, with the phases of end of life care, death and grief have evolved over the years. And now we've got community health care workers now identifying as death specialists. I don't know whether anybody has heard of the term death doula before. We have doulas that help women during labor and delivery, but death doulas have been described as death midwifery. They work with the patient and their families and help to bring about a more comfortable passing. And then technology. When we talk about technology, it has extended and sometimes unnecessarily prolonged life through advanced medical interventions. And we also tend to see the essence of many of our loved ones living on in social media. So, with the advent of social media, um, those social media pages live on. People can still access them. They can still post comments about the loved one that they have lost or the friend that they have lost. So that's another change that we have seen. And then finally, by acknowledging death and loss and incorporating education and support into public health practice, we help to ensure that the end of life care promotes well-being for the individual and their family. So that's kind of where we are with a new era in end of life care. Now, we have to acknowledge the fact that we are growing older as a population. So the U.S. Census Bureau estimates that by 2035, older Americans age 65 and up will be more populous than children under the age of 18, which is a complete shift. And by other accounts, the oldest Americans, which would be persons over the age of 85 years, are expected to number more than 14 million by 2040. So this growing number of older adults, unprecedented in the United States, will actually lead to more individuals living with chronic diseases and more people dying each year. And just to follow up with some other statistics, the CDC has reported that deaths per 100,000 US residents in 2018 doubled between 55 and 64 age bracket, and the 65 to 74 age bracket. And it was more than 15 times higher for ages 85 and older. And that's been a huge shift when we look at that. So these individuals will really need to make crucial choices and crucial end-of-life decisions, but they often don't express their preferences to healthcare proxies who tend to make these choices for them. And as a result, end-of-life courses, and I have personally witnessed many, are often medically and ethically complex. We have medical care that may prolong life, but may not provide for quality of life. And I think that for the vast majority of people, they prefer to have that quality of life as opposed to just prolonging life. So some other problems that we see, there may not be enough caregivers available to provide services as the population of older adults expands. And with that growing availability of technology, individuals are remaining in the community longer, with more complicated health needs and support structures. And that's going to be very difficult to maintain in some of our rural communities where we do not have the healthcare providers that we need. These changing trends will impact all aspects of daily life, from caregiving. We look at city planning efforts to working adults needing to simultaneously care for their children and their parents. I think they've got that term, the sandwich generation, for those people. But on the basis of the numbers that I mentioned earlier, the potential for grief in a community is tremendous. But in the face of death and loss, informed public health professionals can help provide comfort and dignity, as well as being able to provide quality support and education about end-of-life care. So we're afraid of death, but more likely to live. So I know many older adults are very scared about dying, but they're living longer and longer and longer. Did you have a question? Okay. So
They highly valued being able to
within the last 20 years, there's been a substantial shift in the causes of death. So we've moved from really infectious diseases, as you all well know, to sudden deaths. And now we've moved to chronic, long-term, and degenerative diseases. As a result, a lot of public health professionals have been forced to face a new set of challenges, which is, how do we really frame death appropriately, especially at the end of life, as a public health issue? How best can we provide care in the community for those suffering and with those life-limiting and terminal illnesses? And how do we support the dying and the people who love them in living their grief? So the physician and author H. Warich, he wrote that contrary to general perception, never has death been more feared than it is today, and that is very true. He attributes this fear to the number of aging people living through long periods of debilitation due to multiple chronic illnesses and life-threatening conditions. And because of their prolonged and weakened state, these individuals really become more homebound, cloistered within their homes, hidden from others as their end of life nears. And that makes the reality of death to them more terrifying, and causes more grief for those that remain behind. Now, I briefly want to mention the groundbreaking report, Dying in America, that the Institute of Medicine put out in 2015, which highlighted 5 key recommendations, including the need for a collaborative effort in public education and engagement to understand how best to care for the seriously ill. We want to understand that advanced care planning process and how to make informed decisions about end-of-life care. This report also called for increased use of media and other educational methods to promote informed choices and really counter that misinformation that is out there, such as the thing that we heard, especially during COVID, that there were death panels, or that the government has the authority to make decisions about end-of-life care for people on Medicare. And there are people, especially in older rural communities, that still believe that that is what is happening. And we have to work to change that idea. So public health practitioners in the 21st century can work to reduce the burden of poor health outcomes associated with end-of-life care and loss. So I briefly wanted to touch on the differences, because I've been asked, what's the difference between grief and bereavement? So grief is the normal and natural response to loss and death, but bereavement is that period of mourning that follows loss and death. And for some people, bereavement lasts a very long time, could be years for some people, and some people never exit that phase. So public health, how do we respond to loss? So public health, we have a responsibility to look at best practices and braid those best practices with patients and their families' preferences for that end-of-life care. Many people would rather choose to die at home and prefer less aggressive care at the end of life, although such opportunities are not equally distributed because of the unavailability of being able to foster that care at home, especially in our rural communities. So it's important to educate the public and provide community level instruction on how to avoid unnecessary and futile care during this transition period between life and end of life. And equally important is promotion of increased accessible, high quality palliative care, which we see in hospitals. We see in some larger cities, but we're not seeing in our smaller communities. And remember that the palliative care is interdisciplinary and holistic approach to improving quality of life and symptom management for persons and their families. We also need to improve advocacy for greater match between the dying person's wishes and what is actually what they are receiving as far as care goes, because we want to honor that individual's choice. And by honoring that individual's choice, there are many studies out there that show that this lessens the burden by the surviving caregivers. They feel that they have done well by their parent or their grandparent, and lessens that burden of grief and bereavement. All right. Next slide. So how does public health response at the end of life? So public health has a responsibility, like I mentioned, to intertwine or braid those best practices with the individual and family preferences. And equally important, oh, I think I've mentioned that already. Okay, we'll skip that slide. So public health response at the end of life. So there are multiple barriers to accomplishing the aims that we want. First is, while progress has been made, there are many clinicians who are not proficient in assisting individuals and their loved ones with end-of-life choices or bereavement and grief. It's only recently that I've started to see medical training beginning to talk about these issues and deliver proper end-of-life education. And it's very difficult for newly trained physicians who've never had to deal with death. They find themselves having to deal with that during their training, and not only dealing with the death, but dealing with the bereaved families. And that is something that takes time and practice. And we're slowly starting to see that being integrated into educational programs, not just in medical schools, but for all healthcare providers. Second is that information systems are not currently configured in ways that facilitate honoring individuals' decisions related to end of life. So these problems include inadequate interoperability and the electronic health records, which I can talk for hours about, and the problems that has caused. Another thing is really inconsistent methods of documenting end-of-life choices into the medical record. You know, we're all asked about, do we have an advance directive when we go to our physician or we enter the hospital? But if you compare hospital A to hospital B to hospital C, they might be stored in their electronic medical record in the same fashion. And that could be difficult to negotiate for the healthcare workers. Let's see. And then lastly, the current end-of-life preparation really includes discussions about the financial costs of death. So we don't like to talk about cost, but it is in there. You know, the price of funerals in the United States has risen very fast, and as consumer prices for all items related. So we're talking about burial caskets, which have risen almost 230% within the last few decades. And just the price of having a funeral at a funeral home has risen almost twice as fast as well, about 227% in the last few decades. So we need to be cognizant also of that fact about the costs, and help bring that into discussion with end of life preparations for aging and the dying. So though technology has been underutilized in end-of-life care, public health is well positioned to meet the unmet needs of the dying population and their caregivers through technological adoption and advancement. So there's been growing interest in and demand for telehealth monitoring, telehealth in general, digital communications. We have mobile applications to help improve health outcomes. So for an example, older adults who have chronic and life-limiting diseases, especially those who live in rural areas, remote technology services have really offered them a lifeline for the provision of that quality comfort care that we want to deliver to our patients. However, these services can be limited in their scope and reach, particularly in geographically isolated regions due to accessibility, so no internet access, reliability of the access that they may have, the bandwidth, and then a big concern is ineffective reimbursement models that could help minimize that cost. So another thing that has developed and was more widely adopted in 2019 and even more rapidly in early 2020 due to COVID-19 is telepalliative care. So, we had virtual learning communities that have been used by public health and practitioners for continuing professional development and for developing skills and competencies in learning about palliative care and being able to deliver that in isolated settings. So we need to continue to develop those virtual communities to train those healthcare providers that are living in those more rural areas. So beyond medical expansion and virtual training, technology-based industry partners and organizations have also begun innovating in areas of death, dying, and grief. And I'm just going to talk about some things that I wasn't even aware of. And some of them sound a little strange, but so we have podcasts now. We have social media sites that are providing education and support near the end of life. We have, there's voice command technology available that has explored for symptom assessment and pain management. Smart home technology has been used to help with diagnostic assessment and actually treatment. And we've seen a lot of grief-related apps, online grief-sharing platforms, and support networks. So there's mydeathspace.com, there's Facebook Ghosts, there's some augmented eternity programs, different things like that. There's some legacy afterlife services that I've seen. One I know is called Afternote and Virtual Eternity. And most of these, if not all of these, are really geared towards preserving the memory of those that have died in a digital afterlife technology. So we're using technology to really maintain memory of people that we've lost. And that has been studied a little bit and has shown in some small studies to really help in the areas of grief and bereavement. We've also seen some other developments out there. So there is the We Croak app, which I thought that sounded very odd. So I kind of looked into that a little bit more. So what it is, and I'm actually going to read this. It's from a Bhutanese saying that to be a happy person, one must contemplate death 5 times daily. So what this app does, it sends 5 daily invitation to users' devices in the form of quotes and sayings that ponder death and dying, and allows the person to really focus on themselves and how they feel about death and dying. One of the other things that I saw was sound wave tattoos. So the tattoo industry has developed technology to produce these sound wave tattoos, and they use them to memorialize the voice of deceased loved ones, and it can be played through the smartphone. I have not seen it in action, but I've heard people talk about them. We've also seen wearable jewelry for people who have undergone cremation. You can send the ashes to a company and they can make a locket. They make all different kinds of wearable jewelry. I've seen paperweights made from ashes. One of the more recent things that actually came up in conversation with my children was the end of life tree, where ashes are used, and you really just bury them in the ground with seeds, seedling, and a tree grows. My children firmly told me that I will never be turned into a tree because they all started fighting over who was going to get the tree. And they were all concerned about what happened if the tree died. So we axed that choice. So we're still working through what they want to do with ashes. But yeah, the tree. So, but these are all things that really need to be fully researched, and for us to understand their implications. So we need to use those, our public health assessment, policy development, our assurance, and incorporate these ideas into our existing practice because people want them. They are looking at them, they are using them, and we need to understand that and what they are. So when we acknowledge grief, it's long been considered as an adjunct to death and dying, but it's not always understood as a public health or clinical problem, especially when death or loss can't be acknowledged or occurs in those who are socially marginalized. Recognized as a powerful event, both psychologically and physically, grief commonly is exemplified through emotional distress and physical symptoms, and loss, for some people, really a loss of social functionality. For others, it can be characterized by the excessive mortality and morbidity and use of healthcare services following loss. So we've seen that as well. And grief has no duration. There's no set duration. Could be experienced throughout a survivor's lifetime. And there are some researchers out there. So, we've all heard of the stages of grief. We've all worked through the stages of grief. But researchers now are looking to really abandon the stages of grief. They say that it may unduly limit a therapeutic response to grief because of misunderstanding the nature and mislabeling grief as a linear process, because they say that grief is not linear, that grief is a unique constellation of emotions and reactions. So there's no predetermined phase or endpoints for a phase. So they say it's not linear. You can move forward, but you can also move backward. And these researchers are looking at other ways to deal with grief as opposed to just going through those stages. So some policies and legislation. So when we talk about support for individuals providing end-of-life care, that support is difficult to access and many times is inadequate. So at a national level, we have the U.S. Family Medical Leave Act, or FEMLA, and the U.S. Fair Labor Standards Act. They provide limited support for end-of-life care. So one has to be work for a covered employer, so mostly large private employers, public health agencies, and school systems. And they have to have worked for the covered employer for like 12 months and at a location with at least, I believe it's 50 employees. So if those conditions are met, you can get 12 weeks of unpaid leave, but it's job protected. So you have time off to care for an immediate family member. That's only limited to parents, children, and spouses. That's it. No grandparents, no domestic partners, no extended family, no cousins, not even siblings. It's parents, it is children, and it is spouses. So there is only one state that has, which is Oregon, has a law that requires employments to provide bereavement leave, though the individual employer can choose to provide paid or unpaid leave. And then the United States in general is only one of a handful of our industrialized countries that doesn't have a national bereavement legislation. So these are a couple of issues that can be looked at. Then some others. So government agencies and programs have also looked at advanced directives to promote strategy and promote end-of-life care planning. Other policies that are relevant to end-of-life care, so there's a voluntary option to give patients control over when and how they die, while assuring safeguards must be prevented to misuse and abuse these procedures. So these are known as the Right to Die or the Death with Dignity Acts that some states have passed. And what they are is it allows a mentally competent adult with life expectancy of 6 or fewer months to request a prescription medication to accelerate their death. So far, only 10 states, which I have listed here, and Washington, D.C. have passed these laws. And in some of the states right now, there have been efforts to reverse those laws. So I know, since I'm originally from New Jersey, I know New Jersey is one of those states where people are actively pushing to reverse the law. As far as community resources, so government agencies and programs often center on resource location and supportive information rather than participatory activities. There really is widespread misunderstanding about the importance of advanced care planning prior to a critical emergency. So it really needs to be discussed before things get to that tipping point. Some of the issues that I've mentioned before, lack of coordination within the electronic medical record, poor communication between patients, families, and their providers. So we have to facilitate that talk. To address some of these challenges, many local, state, and national programs are being used to promote advanced care planning among the public. We know that Medicare now pays healthcare providers to facilitate advanced care planning sessions within physician offices or hospital settings. And this can really position public health as a real instrument to help advance care-related communication, planning, and education and outreach. And Medicare pays for voluntary advanced care planning under the Medicare physician fee schedule and the hospital outpatient prospective payment system. So that's where some of that money is coming from. So community resources related to end-of-life care. So participation there's evidence, growing evidence, that participation in a grief-related program could be a necessary and effective component of the healing process after loss. Yet there are very few grief-related programs that have been empirically evaluated for their effectiveness. Of the programs that do appear in the literature, there's one that's been found to be theoretically effective, and that provides a framework for how and why grief-related improvements have been reported within the program participation. So in this program, the grievers are exposed to evidence-based curricula designed to influence the different variables of grief that are described as knowledge, attitudes, beliefs, and behaviors. And then there are other programs out there for which there's a lot of anecdotal evidence to support implementation, and they use a combination of different techniques and technological approaches to help support those experiencing grief. And then, okay, individuals nearing end of life whose prognosis is uncertain often receive inconsistent information about their care. And because of this, patients and their families may be experiencing psychological distress due to a combination of factors, including their clinical uncertainty, the poor communication, lack of discussion about certain core issues like preference for where do they want to die? Do they want to be home? Do they want to be in more of an inpatient hospice? Do they want to be in the hospital? We need to start facilitating those discussions. And again, end-of-life decision-making has been further complicated by advanced technology. With many dying individuals and their families lacking the medical knowledge to really make informed decisions about all the clinical interventions that are being offered to them. So the gold standard that we have for establishing best practice, which is the randomized controlled trial, you can't really, it's difficult to implement for education and supportive programs at the end of life. So that is a problem with trying to develop best practices. But some organizations have worked to provide information, and one really good one is through the American Association of Family Physicians, and I have a link to some of their modules in the slides. Then within community and population-based grief-related programming, best practices needs to start with the mitigation of what I call disruptive group dynamics that we commonly experience with implementation and participation in these group programs. So some participants may believe that their loss is more important than others. Others may take inappropriate roles, such as being a moralist or being the advice giver, or they interrupt constantly. So really, we have to look at those population-based initiatives and really manage the characteristics within the group. That's one problem I have seen with some of the community-based programs. Let's see. And you need to make sure that the programs that you do, the community and the population-based grief-related programs, be grounded in theory. So that is also very, very important. So people are very vulnerable at the end of life. So enrollment in palliative care and hospice care at the end of life can increase quality of life for patients and families. But not all patients are equally likely to receive that care. So we've got variables such as race and ethnicity, variables moderated by geographical variation, the availability of county resources can also affect hospice use. Surviving spouse's level of education needs to be considered. We need to take care to minimize the influence of structural factors on access to end-of-life care and provide culturally appropriate knowledge and education to patients and their families. And we need to know that one size fits all is not the way to go. That's not a practical solution. So challenges and opportunities for public health. So while public health has long focused on well-being and not merely the absence of disease, issues related to death and dying and grief don't neatly fit into our normal conceptualization that we have for public health. Another serious challenge is the lack of agreement about what constitutes normal or abnormal outcomes following loss, as well as reliable criteria and valid instrumentation for assessing these outcomes. So the reliability and validity of measurement scales has really been studied. Those measures that assess relationships and social roles following loss are of little value, as you can never fully reestablish those relationships because of the irreversibility of loss. So those typical scales are not the best to assess with. Public health professionals have described a number of processes associated with poor outcomes following loss, and those are included like absent, delayed, anticipatory, masked, disenfranchised, prolonged, or chronic grief. And a person can go through all of those, none of those, maybe one of those. But we have to expect variation in individuals' responses for loss, and there is currently no universally accepted standard for the amount of grief that is too much or too little, nor for when grieving is normal or abnormal. And then finally, there's been a lot of controversy regarding appropriateness of considering depression-like symptoms, which are common in grief, as an illness. So there have been studies that showed that pharmacological interventions used to treat grief-related symptomatology have little to no effect on the grieving situation itself and can actually, in many cases, prolong that grieving situation. So these are some of the challenges that are still out there. And I'd like to conclude with one of my favorite quotes by Paul Coelho. When we least expect it, life sets us a challenge to test our courage and willingness to change. At such a moment, there is no point in pretending that nothing has happened or in saying that we are not yet ready. So that's all I have for you today. I've listed a ton of references that I have used, and I will take any questions.
Thank you, Dr. Morreale. This is very in-depth and informative presentation. We appreciate it. I had a friend growing up who had told his wife anyway that when she dies, he was going to cremate her and put her in the handlebars of his motorcycle. So that's where her final resting place was supposed to be. So we have a quick question. Dr. Hudson asks, in your experience, how does medical mistrust or spiritual belief shape end-of-life decision making? I think this is more along the lines of how do you align end-of-life care with cultural beliefs and values?
Yeah, medical mistrust is huge. Uh, especially in those communities and cultures that have been marginalized in the past. They don't trust what they're hearing. And that is just something that needs to be worked on within those communities. We have to partner with the people within those communities that know those folks and really work to develop and reinforce, trust in us as public health professionals. I don't see any other real way to get around it. It takes work. And you all know from working with rural populations, you're the outsider when you come into a community. And you could be living in that community for 20 or 30 years and you're still considered that outsider. So it's not easy at all to work through that process.
Thank you very much. One other quick question. Do you think what should reimbursement look like or should look like for the profession of death doula or patient navigator with end of life issues? How should reimbursement for that occur?
I really think that we have to work with CMS and private insurers to ensure that there's payment for that. I mean, if you've got a death doula or you're working with a palliative care specialist, um, I don't want to sound cynical, but it really, by paying them, you may in turn actually be saving money because you're utilizing less resources. And that unfortunately is what insurers are looking at. What's their bottom line? So, it's not the way I like to think, but that's the reality of the situation that we're living in right now.
Thank you very much. Well, this is wrapping up our time, and thank you everyone for joining us. And again, to our presenters for presenting and the questions that you guys have submitted. These will be more or less on demand and loaded so people can watch these virtually remotely as well. So thank you all and have a good rest of the week.
Thank you.